Well, good morning, everyone, and thank you so much for joining us today to talk about making your wishes known in the context of the realities of advanced medical interventions. My name is Bill Lombard. I'm a retired nephrologist and live in Bellingham, Washington. I've been was in practice here for about 38 years. During that time, myself, like most nephrologists, end up taking care of a lot of critically ill patients in the intensive care unit, and a recurring experience over time was caring for someone who was no longer able to speak either because of delirium or the severity of their illness, and having their families anguish over what they should do about providing additional care in this person who had a low probability of survival. I would ask them, and they'd say, well, we never had that conversation. We never talked about what we would want to do when we were in this circumstance. An example was a man I took care of. This was my last year in practice. He was in his late 70s. He had had 2 open heart surgeries. He had long-standing hypertension. He had developed a hematologic malignancy, and as a consequence, that developed kidney failure and was started on dialysis. And shortly after that, he came in with overwhelming septicemia. He was delirious, he was hypotensive, and not likely to survive. And I asked his wife what he would like to, what had you talked about what you would do in this circumstance? And she said, no, we never had that conversation. And this is a man that had no small number of medical problems or inconsequential problems where you would hope that it'd come up. So it's because of this experience that when the opportunity came to talk to individuals, talk to folks like you about this, I really thought it was very important to step up to the plate and do so. I'm not affiliated with any organization other than this very small group of people that do the presentations for the realities of advanced medical interventions. Before we get started, I'd like to just say a little bit about the history of these presentations. Kathy McConaughey and Koala Connolly were both ICU nurses at St. Joe's. They now have gone on to other positions. And I worked with them for probably 2 decades. And we often shared the same patients and shared the same heartfelt pain of families struggling over what to do when someone was critically ill and unable to speak for themselves and had not had this conversation, and also saw the toll it took as that patient was treated with all the advanced care we have, day over day, week over week, until they finally died. And because of that, they decided it was time to go out and do something. And I really give them credit for saying, you know what, we need to talk to people about this. Their first presentation was also attended by Mickey Jackson, who I'm sure some of you know. Mickey's a community advocate, particularly in healthcare issues and particularly in advanced care planning. She happened to be in the audience, and Mickey had experienced recently the loss of her husband, and he had gone through this same process and did it the right way, I would say. And he said, hey, you know what, this shouldn't be a one-off presentation. Let's go out and get this to as many people as we can. And I think after finally 40 some presentations, Kathy and Koala over a 4-year period said, I think we've had enough. So after that, Rebecca Cutler, a hospice and home health nurse, and myself have taken on the task of continuing these presentations. So I thank them for having the initiative to do this, because it really was a big step. So why are we here today? Why have you come to join, and why have I decided to present this? Well, talking about and accepting our mortality is not easy. In our Western culture, our views of death are so feared that we are afraid to say the word death. We use euphemisms like passed away or passed, like old Bill passed, and you want to go, well, what old Bill passed anyhow? Do you finally get that test right? Or even better, lost. We lost him, and it's like, well, where'd he go? We just don't want to deal with the fact that death is an inevitability. And death is, in fact, such a feared enemy that we are pretty sure that modern medicine can defeat it. And then dragging out those final days into weeks, and sometimes more than that, we actually deny the natural process of death. As a group, we tend to want to have doctors employ every state-of-the-art interventions to save us. And yet when you ask, most of us will say, I'd really like to die a natural death. So Kermit kind of has it right here. We aren't going to get out of here alive. And the truth is, we are all going to age. We are all going to suffer illness. We are all going to become infirm, and we are all going to die. We cannot change that fact, but we can change how that happens and lay out our wishes for how we want our final days and weeks and perhaps months to go. The way we do that is by engaging in advanced care planning, which we're going to talk about some today. And in the process of that, this makes our wishes known, in which case we will fill out an advanced directive. But in that, we talk about what care we want in the end of life, what's important to us. And very, very importantly is who will speak for us when we are not able to speak for ourselves. And that really becomes one of the critical decision points, because many times we will choose the one that loves us the most, who will also be the hardest to make that hard decision of saying he doesn't want any of these things you're offering for him. So that's really important. You want someone who's going to be strong and who firmly believe is going to say what your wishes are. But before we can make those decisions, we also have to know what's going to be offered to us. And that is what most of this talk is about. What is it I really want at that time? So when, how and when do I decide to get this started? Hopefully before this happens. And this is what happens all too often. And that is, it's so easy to put off doing your advanced directive because it's hard work, and it's you have to face the reality of it. The reality of our own mortality. And it always seems like it's always too soon until it's too late and you're in a position where you have lost the opportunity to have your say in how you want your life to end. These are the advanced medical interventions we're going to talk about today. We'll talk each one, spend time on them, talk about the benefits and or downsides and complications, and maybe if I can, or talk about some circumstances where I think it's appropriate and where it may not be appropriate. The first one is CPR, which is kind of at the head of the list of all advanced directives and any listing of what wishes you want. That is, if your heart stops, do you want to have CPR? What seems like there's a bit of confusion for many people in terms of what a cardiac arrest is versus a heart attack. And it's important to know the difference. First off, a heart attack, so one on the right, is where an artery to the heart muscle itself is blocked, and it's a circulation problem. Cardiac arrest is actually an electrical problem of the heart where the conduction system is no longer working properly, the ventricle quivers and is no longer effective in pumping blood. A heart attack is often caused by is associated with pain, and most individuals that have had heart attacks will tell you this is an undeniable pain, and you just feel like something is desperately wrong. As we mentioned, the artery to the heart muscle itself is blocked, causing this part of the heart muscle to be damaged, and if it's not opened, that part of the heart muscle will die and the heart will not pump as well as it did previously. It's associated with chest pain, but the individual is awake and usually talking. And the heart is continuing to beat and still pump blood pretty effectively. As mentioned, caused by a blocked coronary artery. Call 911, give the patient aspirin, and the patient needs to get to the hospital as soon as possible and into the cath lab so they can open the artery and prevent further damage to the heart muscle, and sometimes even support it so the heart muscle can recover to some extent. Cardiac arrest is associated with sudden loss of consciousness. Occurs when the heart stops beating effectively, you lose consciousness, and death starts occurring within minutes. It's oftentimes caused by coronary artery disease, which may or not be associated with a heart attack, but also individuals with advanced heart failure and cardiac enlargement, severe electrolyte imbalances, or electrical shock or drug overdoses also have cardiac arrest. The treatment for this is you call 911 and you start CPR right away. And the most important thing is to use a defibrillator. So how common are cardiac arrests, and how do we need to be concerned about this? Well, out of hospital cardiac arrests happen in, actually the current number is in the neighborhood of 360,000 per year. In hospital cardiac arrests are closer to 200 to 250,000. So the overall incidence in the United States of cardiac arrest is around 550 or almost 600,000 episodes per year. If you think about that worldwide, we're only 4% of the population, so a large number of humans in this world die from cardiac arrest. In fact, every 39 seconds in the United States, someone dies from sudden cardiac arrest. So how common is it? We talked about numbers, but this just shows you the number of people who die annually from cardiac arrest in the neighborhood of 350,000, as opposed to breast cancer deaths, which are down closer to 44,000. I'm not saying this isn't a lot, but just by comparison, cardiac arrest is substantially higher. This slide just looks at, if you look at all these other diseases, suicides, motor vehicle accidents, HIV, diabetes, colon rectal cancer, breast cancer, and Alzheimer's disease, they make up altogether the equivalent number of people who die from cardiac arrest. As an aside, I just want to point out to you that all things, that maybe this isn't all that bad. If we were in one of Shakespeare's plays, things would not turn out so well for us, and we wouldn't die of a cardiac arrest. Half those people die of stabbings. People get next biggest number of poison, and good Lord, people get actually beheaded, the next most common thing. So maybe cardiac arrest we're better off than what Shakespeare had planned for us. So where do cardiac arrests happen most often? Well, we talked about the number that happened in the hospital. Most sudden cardiac deaths occur at home. 70% occur in the home. Other places include the work site, happens in in airports, in church events, other large event centers, and anywhere where large numbers of people congregate. When the heart stops, as I mentioned, besides calling 911, CPR needs to be started immediately. We've all seen this in TVs, and this is what is actually happening in that circumstances. During the time that the hands are compressed onto the chest, they actually squeeze the blood out of the heart, and when they let the hands come back up and the lungs are inflated and they help the lungs or the heart to refill with blood, you refill the chamber, and this is conducted at a rate of about 100 beats per minute. Sometimes, or maybe some of you have heard of something called the Lucas device. It's some people think it is rather barbaric, but I have to tell you, if you're a first responder, it certainly helps you to have continuation of chest compressions while you're conducting other important interventions, like perhaps intubating the patient or starting an IV so you can give medications. And certainly if you're transporting that person, it becomes a very critical device to use, and paramedics use it quite often. It's kind of, I have to admit, when you see it actually compressing, it seems to compress better than most humans do. And it's thought by many to be somewhat barbaric, but there are studies which actually show that people do better with the Lucas device than they do without it, because of the breaks and compressions, because of the care that needs to be provided by the first responders. The really most important part of CPR, and the hero of this of cardiac arrest, is really the automatic external defibrillator, or AEDs. This device, the patient or patches are placed on the patient, the device here actually reads the arrhythmia and tells you to clear and delivers a shock. And if the patient has a shockable rhythm, such as ventricular fibrillation or ventricular tachycardia, this is what will save them. I was just passing through SeaTac when I was still able to do so, and noticed that there was an AED there. And actually, Seattle, you may know, has AEDs on virtually every corner of the city, and consequently has a higher success rate from resuscitation and restoration of circulation from cardiac arrest than many other cities. So how well does this do? How successful is CPR? Well, this kind of shows you what it looks like. If you take all people having CPR, it's around 7 to 8% are going to survive. If you just do CPR and they don't have defibrillation, it's closer to about 10%. And if the AED is available, it's closer to about 37%. So a shockable rhythm with the AED is absolutely critical to the success of CPR. This is another way of looking at that, and this shows the ambulance response time and the survival of the patients with out-of-hospital cardiac arrest relative to the response time, and whether or not bystander. This is without bystander CPR. This is the blue line is with bystander CPR. But you can see after 5 minutes, this starts dropping off dramatically. And this also looks at survival relative to the minutes until defibrillation occurs. And virtually 10% of survival starts dropping off every single minute. So by the time you get out to 10 minutes, chances of surviving, even with an AED delivered at that time, are unlikely to be successful. This looks at survival according to locations. On the left, we have in-hospital witness cardiac arrest. So these are going to be people in the ICU, and that may be different than these because these people were critically ill. Most people that are in the hospital don't have a witness cardiac arrest. This would be someone on the medical or surgical floor who has a cardiac arrest that can happen any time of the day. There's not someone in the room the whole time, and they're not on cardiac monitors. And so as you can imagine, that's not going to have a very high success rate. CPR by bystander alone, as we saw this before, about 5%. No CPR until the paramedics get there is under 5%. And then CPR with rapid defibrillation with the AED is 30%. This is just a reminder that as we get older, this is age at the top, under age 70, 74, going up in 85 and older. And this is neurologic recovery. And as we get older, because of the vascular changes in our brain, we're just not going to do as well when CPR takes place. And as we get older, that gives us pause to think, is this really something I want to consider doing? So that when you're over 85, it's under 5% that have neurologic recovery, and that's for those individuals who actually survive CPR. This is it's a little bit confusing, but if you just look at the relative length of the lines, this is relative to someone of the number of people that survive CPR. Let's say this is 30% of the total that have no medical conditions. One medical condition, the survival is the same. And if you start accruing more medical conditions, the chances of survival start dropping further. So you take someone with 4 to 8 major health conditions, recognizing that no major health conditions, this would be a 30% survival rate, where they're at 50% of that or so, which is roughly around 15%. So again, as we accrue more medical conditions, we need to really reconsider whether or not CPR is the right thing for us. These are the complications that are common to CPR because of the chest compressions. Rib and sternal fractures are common. Sometimes in the process of the fractured ribs, air can get into the space around the lung tissue and compress it. It's called a pneumothorax. It can also bleed. That's called a hemothorax. Unfortunately, aspiration of gastric contents into the lung is also common, so that even if the patient survives, they then have to deal with aspiration pneumonia. They can actually get contusions of the heart and lung themselves just from the compressions. They can also lacerate their liver, sometimes from the hyperextension of the neck to provide adequate airway respirations, either with a bag, mask, or trying to intubate them. Cervical injuries can occur. And then you can also bleed into the pericardial sac itself because of the chest compressions again. So what are the survival lessons we want to take away from looking at CPR? And the question is, do I want CPR or not? Well, where are your accounts? If you're in the hospital with an acute medical illness and you don't have a lot of other medical conditions, you're a reasonably good health otherwise, being resuscitated is reasonable. If you have an unwitnessed cardiac arrest at home and there's no one else there, it's of course will not happen. And if someone does happen to find you some minutes later and try to get started, the chances of survival are low and the chances of neurologic injury are extremely high. So who is there at the time is very important. If there's a bystander who can initiate CPR and quickly summon help with 911, that's increases your chances of survival. If you happen to have an AED in your house, it'd be very convenient, but that's not very common unless people have already had problems with their heart of that nature. If the ambulance takes 15 minutes to get to your house, it's going to also dramatically decrease, as you saw, even with bystander CPR, that curve drops off pretty quickly by 10 minutes. As I mentioned, age has a significant factor in terms of survivability and other medical conditions. For example, patients that have advanced cancer, stage 4 cancer, don't do as well with resuscitation. Basically. So the next group of interventions we're going to talk about, which were a big list, are kind of like do everything. And I can tell you I've heard that many times. And I just want you to know this is what do everything looks like. And this is a patient who's on continuous renal replacement therapy, an intra-aortic balloon pump. You can see that there's at least 4, 5, 6, 7, 8, 9, 10 drips going, various drugs going in to try to keep this person going. And it is a lot. And he's also on a respirator. And we have to realize if we say we want everything done, everything is a lot. And it's a lot of interventions and invasive procedures. Things are done that have risk associated with them and harm, and in the right circumstance, they will help. The question is it the right thing for us at that time? Next, we're going to talk about intubation and mechanical ventilation. This is most often used in circumstances where someone comes in unable to breathe and not able to get enough oxygen into their bloodstream or unable to get enough carbon dioxide out of their bloodstream. And a tube is inserted through the mouth and comes back and into the trachea. And then there's a little balloon thing here, which is inflated up here. And when you inflate that, it creates an airtight seal. And that way, when air is forced in here by a ventilator, the lungs can inflate without leakage around it. Additionally, this tube protects the airway. So if this is the esophagus, if gastric contents were to come up, they're less likely, not foolproof, less likely to get into the lungs and cause aspiration pneumonia. You can see how a tongue can obstruct an airway. This is why we lift people's heads back, because when you do that, it pulls the tongue forward. But also, if someone is going to be unconscious and not breathing very strongly, they can also be intubated just to protect their airway. So that's what endotracheal intubation looks like. And this is what a mechanical ventilator looks like. First off, most always, when someone's on a ventilator, they have to have a nasogastric tube. Again, you're trying to keep the stomach contents empty so it doesn't leak back up and get into the lungs. This is the endotracheal tube we talked about. Air is coming from here where it comes out of the ventilator with this oxygen added to it to the amount required. So it comes in, it is humidified, goes into the patient, and then as they exhale, it comes back out, gets filtered, and goes out. And then there's usually a lot of complicated settings regarding the amount of pressure that the breaths are supplied under and how fast they are, because that will determine their respiratory rate and how quickly they get rid of carbon dioxide. And the oxygen content of the air coming in will decide, show how well they're getting oxygen into the bloodstream. This is not an uncommon circumstance to see in the ICU. This individual is on a ventilator. It's over here, has a nasogastric tube. Almost always they have to be restrained so that they don't, it's a natural reflex, you just want to pull that out. And if you do, you create a critical situation right now to try to get them reintubated because they're obviously on the ventilator for a reason. What are the risks associated with mechanical ventilation and intubation? Well, delirium is very common in circumstances where it's required. Big consequence is that they're unable to communicate, which means you may not be able to ask them what they want to do, if they want to stay on the ventilator, or if they're feeling, if they're in pain. We sometimes get them to write on a tablet for us. You can get lung damage from the endotracheal tube, and mostly from the mechanical ventilation. You can overinflate lungs and actually cause air leaks to occur, and then cause that pneumothorax circumstance again, where the lung collapses around it. Injury to vocal cords and trachea are not uncommon. One of the toughest things is when you can't wean them from the ventilator. They're never able to breathe on their own again, and that would then require a tracheotomy, which is this device, and just what that little tube looks like. If they can't get weaned from a ventilator and yet they're alive, awake, and doing okay, they sooner or later are going to require long-term placement in a nursing facility, and the closest one that accepts people with tracheotomies is in Seattle. This is a big deal. What circumstances would intubation and mechanical ventilation be required? Well, it can be something as simple if someone has an inadvertent drug overdose and they're admitted to the hospital and they can't protect their airways, so they're intubated, put on a ventilator overnight, and they're detoxified, or somehow the drug is removed from the body, like for example, by dialysis. But you protected their airway, and the next day it comes out and everything's fine. If someone comes in that has an acute pneumonia, which this happens often these days because of COVID, and this is a common event with that disease, they have low oxygen levels in your blood. They try putting them prone and it doesn't help. Then they end up being put on a ventilator. And then you just don't know if it's going to get better or not, because not everyone responds the same. If you are otherwise young and healthy and had good lungs, not unreasonable thing to do at all. If you already have advanced lung disease, if you have COPD and you get pneumonia and require being put on a ventilator, I'm afraid those are the folks that oftentimes end up in failure to get off the ventilator, just because their lungs are so weak for starters, and their respiratory muscles are weak, that when you give their muscles a rest by putting them on the ventilator for 3 to 5 days, the muscles just begin to atrophy and don't work as well. So again, what situation you're starting with is the critical point in making the decision of whether you want that and whether it's expected to be long-term or short-term. Someone asked about ECMO, and I'll just cover that briefly. ECMO is extracorporeal membrane oxygenator, and it's basically an artificial lung. And it basically involves going on a type of heart-lung bypass. So blood is taken out of the body, goes through a membrane oxygenator, and then returned. This occurs when you're on a respirator, you're intubated, and you're using 100% oxygen, and you still cannot get adequate oxygen levels into your blood. So basically, you shunt the blood away from the lungs, give them a chance to heal, and then return oxygenated blood to the body from the machine. I have seen that work in young people with severe respiratory illnesses like severe influenza or severe pneumonia, where they bought days to a week or maybe 2 in time, giving them time for their lungs to heal. For people that are desperately ill otherwise, it's a It's a big step, big chunk of therapy, big intervention. Talk about vasopressor drugs to support blood pressure. These are commonly used in the ICU, and they're used to treat shock and raise critically low blood pressures. They act very much like adrenaline to increase the blood pressure by stimulating contraction of the blood vessels in the body, increasing the force and the rate at which the heart pumps blood. It increases blood flow to, quote, the vital organs, which basically means the aorta and the large blood vessels after that. But there's also a lot of collateral damage from those, including to the skin. People can lose digits. Kidney failure is common, and they can also have intestinal ischemia, where the intestine does not get adequate blood supply. These are all administered by means of a central line. So usually the intensive care unit physician will place a catheter through the skin into the line so that these medications can go into a vessel where there's a large blood flow. This was a young college girl who came in with septic shock, and she survived. And as bad as this looks, she was on high doses of 1.3 different drugs to raise her blood pressure because her shock was so severe. She survived. She lost the tips of some of her fingers, but otherwise she considered a reasonable trade-off. As we get older, things won't do so well. People can lose multiple digits and lose even lower extremities in circumstances when they're in high dose suppressors. Again, these are usually most often used nowadays in people who come in with either cardiogenic shock from severe heart damage from a large heart attack, large myocardial infarction, or in people who come in with overwhelming infections. They are often used hoping that you'll only have to use them for a very short time to get them over the hump until the infection can be taken care of or something can be done to help their heart. If they have to be used for days on end, they do have a lot of consequences that are not pleasant to deal with. So now we're going to talk about circulatory assist therapies. That is in circumstances of severe heart failure where the heart can no longer pump adequately to get oxygenated blood to all the organs effectively. There's basically 3 therapies that are used for this. One is the use of intravenous medications. It is very short-term only, and if they don't work over a period of 2 to 3 days, they are not going to work. And they basically are very marginally effective. No drugs have been developed that certainly make this better. Most often, it occurs in the circumstance where someone comes in, as I mentioned before, severe heart attack, maybe with either the main coronary artery blocked or 2 of the secondary coronaries, and they go to the cath lab and they open them up and the heart is sort of stunned and it's not working very well. So one of these other devices might be used then to just get them over the hump and hopefully raise the blood pressure enough that the blood pressure in the aorta is getting blood flow into those coronary arteries so the heart muscle can recover. This is what an intra-aortic balloon pump looks like. It's inserted usually in the femoral artery, which is down at the groin. The catheter is then inserted up and stops just below the arch of the aorta. When the heart is actually pumping here, as we see during systole, boom, the flow goes out around the catheter to supply blood below it. And when it goes into diastole, when it's refilling, the balloon inflates, and what that does is it keeps blood flow coming back to increase the blood flow to these coronary arteries to allow the heart muscle to recover. Usually by 10 days, rarely is it 10 days, usually 2 to 3 days, it's going to be successful or not successful. In more advanced cases, there's actually something called a left ventricular assist device, and this is virtually a pump which takes blood from the left ventricle through this little pump and back up and into the aorta. This is called an LVAD, or left ventricular assist device. It comes out through the skin, then goes to a controller, which defines exactly how this will work. And then these are battery packs, which supply energy to this, which then supplies the energy which runs the pump. Interestingly, when you examine these people, they don't have a blood pressure or a pulse anymore. It's a continuous flowing pump. So I have to tell you, it's kind of spooky because you go, how's this work? And they're sitting there talking to you with a smile on their face. Um, this is what it looks like in real life. Here's that same device, batteries, and then this is where it goes into the skin. We had at the cardiac program at St. Joe's had a LVAD destination program. So destination meaning these people have end-stage heart disease. They are not candidates for heart transplants, and an LVAD is placed to keep them going indefinitely. And the best I know is someone who lived about 10 years with one. The original design and intent of the LVAD was to provide a bridge to transplant. The classic example is, let's say, a woman who develops postpartum cardiomyopathy. This is a very uncommon circumstance where at the terminal portion of the pregnancy, the baby is delivered, the mother's heart muscle stops working, and they develop severe dilated heart failure or dilated cardiomyopathy, and they will die. And the hope is that what you do is you install an LVAD and give them a breach to the time when they can receive a transplant. Heart transplants aren't, hearts aren't just sitting on a shelf somewhere where you need one, you go and pick one off. You have to wait for a donor to be available. So those are the left ventricular assist devices. They are not easy. They typically result in prolonged hospital stays. Kidney failure is not uncommon. This was a lot of my experience with it was during the ICU right after their placement. Vascular injury is common. Infections are common and dreaded. There are long-term anticoagulants, so bleeding is a potential problem. The pump itself, that little mechanism, can actually clot if the anticoagulation is inadequate. You can also get partial clotting and clots that get thrown through the pump, and obviously it can cause strokes and other problems. So it is, in terms of advanced medical interventions, this probably takes the cake in terms of the most advanced. Before we go into the next question, next topic of kidney failure and kidney replacement therapy, are there any questions about circulatory assist devices? So let's talk about what happens when kidneys fail. Renal replacement therapy, dialysis of one form or another, is usually needed when kidneys fail, typically caused by shock circumstances. Most commonly nowadays, that's associated with overwhelming infections or sepsis, but also in cases of severe heart failure. Occasionally, in people who have pre-existing kidney disease, the administration of intravenous dye, as for example, for a CAT scan or even a cardiac catheterization, can result in kidney failure. And there are certain medications which contribute to it. When kidneys fail, we no longer balance fluids normally in our body. Fluids build up oftentimes in our lungs, causing shortness of breath and ultimately hypoxia or low oxygen levels. And the body actually becomes toxic from the waste products and from electrolyte derangements associated with it. When someone has acute kidney failure in the hospital, they require a catheter. This looks similar to what we showed for pressor drugs, where this is a much larger catheter. It gets inserted into the internal jugular vein and sits in the right atrium. And with this, blood can be taken out, run through a dialyzer, and returned. And that's shown in this schematic, which is, this uses a forearm fistula like you would see in someone with chronic renal failure. But the principle is the same. Blood is taken out through a very complex machine in terms of the pressures and the blood flow rate that it accepts. It goes through a series of capillary membranes with clean fluid on the outside, and the waste products go out into that and go into the drain, and then the clean blood is returned to the patient. It's really, this is the way dialysis has been going on since the late 1960s, and I have to tell you, it's still quite primitive, but it works. It's what we have for now. This is what outpatient dialysis would look like. Here again, this is a fistula, same venous and arterial needles, blood's coming out, going through, ultimately through a dialyzer and back through, and blood thinners are administered so it doesn't clot in that system. And this is what dialysis looks like in the critically ill. And this is with a continuous renal replacement machine where people are dialyzed for 24 hours continuously, oftentimes for 3, 5, 10 days in a row, where you can basically completely replace kidney function with that device. What kind of problems do we see with acute dialysis or acute renal failure and acute dialysis? Well, the biggest one is the failure to recover. You always have to face the fact that as we get older and you add on to that additional health conditions like hypertension, heart disease, diabetes, the chances of ultimately ever recovering your kidney function goes down. Example I would use in the hospital is if someone is 30 years old and they came with acute kidney failure from a bad muscle injury, let's say, or blood loss, they've got about a 70 to 80% chance of recovery. Each decade you go above that, you take 10% off that number. So that by the time you hit 60, you're talking about closer to 50%. When you get up into the 80s, you're talking about 20%. If you add on to that an 80-year-old with heart failure, diabetes and hypertension, I can tell you that they're not going to come off dialysis. And that means if you start this, then you're going to have to face issue that they're going to be on dialysis the rest of their life. And so that's a real important question to get answered from the get-go and ask about. What are my chances of recovery? Infections of the catheter is another one of our dreaded issues, and it can cause sepsis and removal of the catheter, and it creates a lot of additional complications. The access may malfunction, and you find that you're not even able to dialyze the patient. They receive blood thinners, so hemorrhage is possible from that. If too much fluid is removed during dialysis, the patient can become hypotensive or go into shock. It's usually addressed right away by the nurse doing the procedure, but it still is a potential problem. And if electrolyte abnormalities occur or the stress is too much for the patient, they can also have a cardiac arrest. So, acute dialysis. As you may have seen, my bias is if you have to take into consideration what else is going on, how old am I, how many other medical conditions I have, and what are my chances of recovery. Those are the questions I would ask myself if I wanted to, whether or not I would want to have dialysis. Artificial feeding is one of those other issues that people oftentimes are very clear yes or no about what they would want to consider. Eating is certainly something that is very personal to all of us. I mean, like if I can't taste my food, frankly, I may not want it, and if it's bypassing everything and going into my stomach or my intestinal tract, is that a way I want to live? Obviously, if it depends, is it going to be long-term, short-term? This just simply shows the various types of artificial feeding. First off, the most intensive form is called total parenteral nutrition, or TPN, where again, it's a high concentration of amino acids, glucose, and fats are administered by means of a central venous catheter. Again, you have to be in a big vein so you don't get complications of thrombosis in the small veins. It can be peripherally administered in smaller, lighter doses. TPN is utilized for people who cannot take anything into their intestinal tract. The more common form is by means of nasogastric tube, so it goes in through the nose into the stomach, and hence nasogastric, or it becomes nasoduodenal when it goes into the duodenum, or nasal jejunal when it goes all the way into the jejunum. You can then also have tubes entering through the skin, then it becomes a gastrostomy tube, or a jejunostomy tube, which goes through the skin and into the jejunum. Generally speaking, putting large amounts of feedings into the stomach is a high risk for aspiration. If you trickle it in slowly, not probably going to be a problem. If you're going to provide any type of significant volume and adequate amount of nutrition, you really want the tube to be in the jejunum if possible, because then the intestinal tract, and most of these tube feedings are already broken down into the elements of amino acids and others, small pieces of protein, so they don't have to undergo a lot of digestion that the stomach contributes to. When they are needed, they can be very beneficial. The question is it going to be short-term, long-term, intravenous, which I think, again, typically you should have a very defined endpoint for how long that's going to be going on. The reality of this, unfortunately, we see many times, this is an older gentleman who's had a stroke and he's getting tube feedings. He's restrained and his tube is placed up here so he cannot grab it and pull it out, because I cannot tell you how many times I've had people with tube feedings where the tube gets pulled out, and you just want to say, I think this person is telling us something. They really don't want this going on. And these show the complications of enteral. Now, this is tube feeding into the intestinal tract. It can become malpositioned. One of the worst things to happen is for the tube to be pulled out. So now the feedings are going into the esophagus, where they build up quickly and result in aspiration. They can be dislodged. Sometimes they get blocked and they don't work. And then you go through, how long do you go without feedings before you replace the tube? They can get erosions of the skin from where the tube goes in, and also the lining of the nose and the back of the throat. And again, aspiration is the biggest worry I think we have. Diarrhea is probably the most common gastrointestinal complications. And then they can also, because of the diarrhea and other issues, end up with electrolyte disorders and also deficiencies of vitamins, minerals, and trace elements. And also, if they're getting any oral or tube-placed medications, oftentimes you can have adverse reactions where drugs are absorbed onto the feedings you're giving them, and they never get adequate absorption of the medication that you're trying to provide for them. So, artificial feedings, talked about intravenous, tube feedings by nose or through the skin into the stomach or to the jejunum. Any questions on those? No. Okay, I'm going to tell you that I tried to add a whole segment on advanced cancer treatment, and I just found this to be so overwhelming I couldn't accomplish it. And the reason is that there's so many different types of cancer. There's so many different types of therapy. And I will show you at least a website I found, which was extremely helpful in terms of one of my big questions is, how do you know when you're offered a drug trial if it's the right thing for you? And how do you evaluate that? And I think that would be is the most important thing. This is just a brief look at, these are the highest number, or the cancers rated by their most frequent to less frequent. And this is only a fraction of the cancers, of course, and these are in numbers, rates per 100,000. Two most common, probably not surprising, are breast cancer at 126 or 127 per 100,000, prostate cancer 107 per 100,000, lung cancer 53 per 100,000, and it goes down from there. Interestingly, when you then look at cancer deaths per 100,000, so if you remember, lung cancer was 50 per 100, or 54 or 52 per 100,000, what's 35 per 100,000 in deaths. So you can see that this is one of the more deadly forms of cancer. Much higher percentage of people with lung cancer die than people with others. Breast cancer, which was most common at 136, is only at 20,000 in terms of the cause of death, 20 per 100,000. So again, we have great therapies for breast cancer. I mean, it's, of course, and again, breast cancer is not just one type of cancer. It's several different histologic types, multiple different stagings, and there's radiation, there's various chemotherapies. Likewise, prostate cancer was 107, and only it's down per 100,000 is basically 19 per 100,000 in terms of the cause of death. So for some cancers, we do well. Some we don't do so well. This is the site that I found in researching this, oncolink.org, and this actually walks you through there's a whole article just on evaluating chemotherapy clinical trials. And if I were receiving chemotherapy and someone offered me a trial, I would go and look it up and find out, because sometimes the improvement with them is fractional. I mean fractional. That when they say there's a 25% improvement in survival, and you find out it turns out it's an additional 2 weeks or a month, but it's also associated with a lot of side effects. You want to say, I'm not so sure that that's a great trade-off, you know? And so I would just ask that whenever you're looking at what your therapies will be for this, you want to say, what can I expect in terms of improvement, and what are the side effects, and what are the hospitalization rates, and high-grade complications seen with this therapy. So let's talk about another advanced medical intervention, which is less interventional and more care providing, and that is palliative care and hospice care. So what is palliative care? Well, palliative care is really a specialty of medicine now, which deals with people that have serious illness. And the care is focused on relieving pain and suffering of those people, just no matter what age, no matter what stage of their illness, and whether it is curable, chronic, or life-threatening. And the goal is to improve the quality of their life, both for the patient and for the family. And there's oftentimes a lot of confusion about palliative care and, well, isn't that the same as hospice care? And it really isn't. And we're going to show a comparison of those two in a second. This is a great slide. This for me is like, puts everything in perspective in terms of how we care and should care for things. So let's say that here I am, a 70-year-old guy, and I get non-Hodgkin's lymphoma. Well, early on, I know that this is a disease which has a fairly high cure rate, and the therapy is not easy, but it's been around a long time. So I take 6 cycles of what's called CHOP, and during this time, my focus is going to be on curative therapy. And let's say that I did okay, but I'm also going to I'm going to touch base with the palliative care people and say, hey, my life is changing and I need some help with this. And I may be having pain, I might be having weakness or adverse effects, and I can get some help from palliative care. And so time goes by, and now let's say 6 months later, I have recurrence. I start therapy again, and I get no response at all. So now things are changing. Now my care, rather than being 100%, it might be initially 100% focused on curing again, I'm going to start moving along this continuum and have palliative care more and more involved in my care until I finally reach a point when I say, you know what, this isn't working anymore. I don't want any more chemotherapy. I don't want any more radiation. I'm done. I just want to be comfortable. I don't want to go back in the hospital anymore, and I'm okay with that. And at that point, would also have hospice engaged in my care. And again, when we have hospice care, we're not going to be hospitalized again. We're basically accepting that we have a terminal illness that will cause our death within 6 months. And the other thing is that both hospice and palliative care folks do help with care and bereavement of family members after I'm gone. This is a slide that just shows that the most hospitals anymore have palliative care available in them and for their outpatients as well. And this is this is a 2014 slide. I'm sure it's higher at this point. And we know that, I know in Bellingham and in Skagit counties, there are palliative care services as well. The benefits of palliative care, and this has been shown in non-randomized, meaning observational studies, that without any decrease in their survival rates, the patients rate that they have reduced pain and reduced distress, that their health-related quality of life scores are higher. They have higher patient and family satisfaction with care. There's a higher likelihood of their location death being outside the hospital. And they also have reduced number of hospitalizations and reduced ICU lengths of stay. This has also been looked at in the frail elderly that have chronic kidney failure, which has approached or is at the point of end-stage renal disease, where dialysis would be recommended under many circumstances. And when you look at those folks who are going on dialysis versus getting palliative care, it is exactly what you see here. They end up living just as long as those frail elderly as they go on dialysis. And they're not in the hospital, they're not in the ICUs, and they die at home. And they have a much better quality of life. And it's not an easy decision for many people to make, but it is something that definitely needs to be considered. And I think increasingly we've come to look at this in the nephrology world. So again, this compares, shows the similarities and the difference between palliative care and hospice care, trying to clarify that blurred margin sometimes. First off, both of them are involved in aggressive pain, symptom, and quality of life management. For palliative care, the patient has a serious chronic and or life-limiting illness, In the case of hospice, they have a terminal or untreatable illness, which is expected to cause their death within 6 months in its normal course. The care philosophy centers on a team approach that includes patient, the family, and the primary care provider, as well as the palliative care people. The same is true of hospice care. That is another shared feature of both of them. And then in palliative care, the patient may be seeking still continue to receive curative treatment, which, for example, might be dialysis, it might be chemotherapy, it might be advanced cardiac interventions in hopes of improving their care. Patients that have, as we talked about before in that continuum, when you've reached the point of saying, I'm not seeking curative care anymore, I'm not returning to the hospital, then hospice is probably the better option, or it shifts more towards hospice and than palliation. Any questions about those two? Where do we go from here? It's a long and winding road, and it goes on for a long way. But where are you on this road? This is a statistics of how we look at end-of-life care. And if you start up here, 90% of people believe that talking to their loved ones about end-of-life care is important. About a quarter of them actually do it. 80% say that if they were seriously ill, they would like to talk to their doctor about end-of-life care. 7% actually have an end-of-life discussion with their physician. This is everybody's, both sides got to take a role in this, because this guy and gal and the patient both need to bring this up. 60% of the patients think that making sure the family is not burdened with the tough decisions is important, but only about half of those actually have committed, less than half have committed their wishes in writing. And 82% of the population thinks it's important to have in writing. A quarter actually have done so. So advanced directives and POLST forms in the appropriate individuals is how we correct that. This is what they look like. And I'm just going to look at these very briefly today to help you understand a little bit of the differences. I understand that you have coming up an advanced care or an advanced directive workshop to go through the actual steps in filling out your advanced care plan. This is the one that is most commonly used around here. It's in the Honoring Choices Pacific Northwest. And I'll show you the website to obtain that. It's actually a great form. It's fairly lengthy, but it walks you through the whole process of what is, just like you said before, Bonnie, what's important in your life? What are the things without which life would cease to be as important? And what are the things, if you continue to do? For some people, it's just, I get to see my grandkids every Sunday, and you know what? That's good enough for me. But also very important is the first portion of the advanced care planning helps you choose who is going to talk for you when you're unable to. And so I mentioned before, that is critically important. And while I'm talking about it, I just want to mention now that I know in the New York Times in the last several months, and also there's an article in JAMA that talked to our failure in the advanced care planning, that basically, despite the efforts for this over the last 10 years, there has been very little change in the number of people that end up, for the length of time they spend in the ICU, the number of people that die in the hospital, and the number of people that die in the intensive care unit. And they cited as the principal reason, failure of the people to follow the advanced directive for the individual who has requested it. That's why this choice is so important. You have to, our spouses may not be the best person for us. They're the one, as Judy said, they're our loved ones who want to keep us going. But that may not be what we want for ourselves. So just be sure that you choose a strong-willed person that will follow your wishes in that circumstance. I was the durable power of attorney for healthcare for my parents, and every year at Christmas or Thanksgiving, I would sit down with them and say, okay, folks, it's that time again. Let's go through this and make sure I got this right. And that's what you want to do if you are someone's DPOH, or if you are someone who has a DPOH, which we all should have. The POLST form looks like this. As I mentioned before, previously was physician's order for life-sustaining therapy. Now it's the portable order for life-sustaining therapy. This is generally for people who have a serious medical condition, and the rule of thumb when I was in practice was if you saw a patient in the office and you thought that you would not be surprised if they died within 6 months, they should have a POLST form. So we've already talked about those. So again, this is the form. You can find it at www.choicespacificnorthwest.org. The POLST form, again, it's a set of specific medical orders in terms of CPR, no CPR, what therapies, what advanced medical therapies you want. You keep the original, it is that color, is that fluorescent or sort of chartreuse fluorescent color, and it should be in a very obvious place within your house. Most people attach it to the refrigerator. As I mentioned, that's where the EMS personnel go to look for it typically. It is not the same as advanced directive. It doesn't go into the things that you want at the end of life, other than very specific medical orders. As I mentioned before, the emergency medical personnel must follow those orders, and without a POLST, emergency care staff are generally required to do everything they can to try to resuscitate you and keep you alive. This is what the POLST form looks like. Name, etc., filled in here. Medical condition. Again, the first one is use of CPR, yes or no. And then this is medical interventions. Full treatment is one. Remember that picture I showed you at the very beginning? If you say full treatment, that basically says all the things that the medical team has to offer will be used. Selective therapies are you can say which of these you want, which you don't want. And then you can also say, you know what, I just want comfort-focused care. And then it's signed, and also has to be, again, signed by your primary care provider or whichever provider is helping you fill it out. And this is a great slide also. And this is how advanced directives and the POLST work together. First off, all adults, and I'm going to say anyone over the age 18, should at least read through and complete an advanced directive. They should at least look at it and kind of know. And you know what? 18-year-olds got to know also they're not going to live forever, and things happen to them also. As we get older, this should be reviewed on an annual basis, and then you should have a POLST form completed if you do develop an advanced illness or frailty of some sort, and then that POLST should be updated. So let's say that we go back to the circumstance when I talked about, let's say that I had non-Hodgkin's lymphoma. You know, when I get that diagnosis, I'm going to have a POLST form. And after I've maybe been what I think is cured after the first 6 therapies or round of therapies, I might change it. And when it recurs, I can guarantee I'm going to update my POLST form and change it if need be. And hopefully by doing so, our treatment wishes are honored. So what do we do with all this? Well, first, have the conversation with ourselves. What are the things we would want at the end of our lives if these illnesses befall us? Importantly, we need to choose who will speak for us when we can't communicate for ourselves. We should discuss our wishes with them and all of our loved ones. We should attend the advanced care workshop as soon as possible. And it's really good, and what we found worked really well before is to have this advanced medical intervention presentation and then have a workshop just as is planned for Anacortes, so people can fill out their advanced directive after looking at this and knowing what the options are. And then go ahead and complete your advanced directive and POLST if it's appropriate for you, and file a copy of it with your spokesperson and with your healthcare provider. Things to remember: everyone should have an advanced directive over the age of 18. Those with a serious illness, heart failure, lung disease, kidney failure, or malignancy should all have POLST forms. Have the discussion with your family and your doctor. This is a shared responsibility between you and your doctor, not just him and not just you. Know what the realities of your care are that you want, and now is the time to start. It's always too soon until it's too late. And remember, it is a family affair. Well, thanks everybody for hanging in there. It was a bit longer than I expected, but I appreciate your attention and most people sticking in there for the whole talk. And again, if you need to contact me, please feel free to. Okay.